Welcome to the Deep Dive. Today, we're taking a close look at hypomania. You've probably heard it described as undermania, or maybe less than mania, which gives you a kind of general idea.
Right.
We've gathered some really detailed information on this, and our goal today is really to unpack exactly what hypomania is, what it looks like, thoughts, behaviors, and why understanding it is important. And we'll try to do this without getting too bogged down in overly technical jargon.
Good plan.
So we're going to explore its main characteristics, how it's different from other mental states, and some of the more complex bits around it. Okay, let's get into it.
Right. So as you said, the term hypomania does literally mean under mania, less than mania. But it's really important, I think, to see it as its own distinct psychiatric behavioral syndrome.
Okay.
At its core, you're looking at a noticeable elevation of mood. Maybe euphoria, intense happiness that doesn't quite fit the situation,
Out of context.
Exactly. And this can lead to behavior that's just persistently more outgoing, more uninhibited than usual for that person.
And it's not always just feeling like euphoric, is it? One thing that really struck me in the sources is that irritability. That can also be a really significant part of it.
Oh, absolutely.
Sometimes apparently just as intense as in full mania, especially they mentioned in bipolar 2 disorder. That seems key.
It is absolutely key. While we often picture hypomania as just that elevated mood, irritability is very well documented, especially, like you said, with bipolar 2.
Right.
Now, the really critical difference, and the sources emphasize this, especially looking at the DSM-5, which is the diagnostic manual.
Right, the standard guide.
Yeah, it's the impact on functioning, how someone functions in daily life.
Ah.
In hypomania, crucially, there isn't significant functional impairment. And psychotic features like hallucinations, delusions, they aren't present.
Yeah.
That's the major dividing line from mania. Mania does involve significant problems with daily functioning, and it can include those psychotic features.
So if someone's hypomanic, they might be buzzing with energy, maybe getting loads done, but they're generally still sort of managing their day-to-day life.
Pretty much, yeah.
Whereas someone experiencing full mania might be struggling just to, say, get to work or keep things together because their thinking is too disorganized or they're too impulsive.
Precisely. That difference and how much it disrupts your life is a really important diagnostic clue.
Got it.
So, moving on to the main symptoms and behaviors. Our sources highlight several key things.
Okay.
One of the most noticeable is a reduced need for sleep.
Right.
Paired with a general increase in energy levels, people might find they only need, 3-4 hours sleep and still feel incredibly wired.
Yeah, I can see how that might initially feel amazing, like you've suddenly got all these extra hours.
Totally.
But I guess that's not sustainable.
It rarely is, no. And along with this energy, you often see unusual behaviors, actions, and a really marked increase in talkativeness and confidence. This can sometimes manifest as what's called a flight of creative ideas. Thoughts seem to rush in, one after another, maybe jumping topics really quickly.
That sounds almost exciting, but I can also see how it can get really scattered, hard to focus.
Exactly. Hard to pin anything down. Our sources also mention other related symptoms like feelings of grandiosity.
Like feeling overly important.
Yeah, an inflated sense of self-importance. Also, increased distractibility and sometimes hypersexuality. And while this state can lead to periods of high productivity, real excitement, the potential downside is there. Increased risk of impulsive or risky behaviors.
Like what sort of things?
Oh, maybe impulsive spending sprees, making rash investments, relationship problems due to irritability, or just saying things that are really out of character. Difficulties in everyday life can definitely creep in.
So it's like you might get these bursts of amazing output, creativity, and some people with bipolar disorder even see it as an advantage sometimes, maybe in certain jobs.
Right, especially creative fields, perhaps.
But there's also that real risk of things just going off the rails, becoming problematic.
That's a very good way to put it. It's often described as a kind of double-edged sword.
Yeah.
Our sources also suggest hypomania can sometimes be like the first stage on the way towards mania.
Good.
Where those core features, the euphoria or irritability, the rapid speech, hyperactivity, energy, less sleep, racing ideas just get even more pronounced.
Right.
But again, it's vital to remember people in a hypomanic state are typically still able to function in their daily routines. That's the key difference from a full manic episode.
Okay, so let's really try and nail down how hypomania differs from other things. We've covered mania pretty well. What else?
Well, like we said, the absence of psychotic symptoms is huge. That's a major differentiator from mania.
Right. No delusions or hallucinations.
Exactly. And the lesser impact on your ability to function day to day. That's the other crucial point.
Okay.
But our sources also connect hypomania to specific conditions. It's a defining feature of bipolar II disorder and also cyclothymia. It can also show up in schizoaffective disorder. And like we talked about in bipolar I disorder, as moods shift around, maybe coming down from mania.
So it's not really diagnosed on its own, is it? It sounds more like a component, part of a bigger picture of conditions involving mood regulation.
Precisely. It's part of a pattern. Now, you mentioned the potential upsides earlier.
Yeah, the creativity link.
Right. And it's true, hypomania is sometimes associated with increased creativity and productive energy. Some individuals with bipolar disorder do find those phases give them a real boost at work, intense focus, maybe rapid idea generation. It's a really interesting, complex area.
It really is. Makes you think about that fine line, doesn't it?
Definitely.
Our sources also brought up something called hyperthymia. What's the connection there?
Hyperthymia. Sometimes it's called chronic hypomania. It basically describes a state where someone experiences symptoms similar to hypomania, but more long-lasting, persistent.
So not really distinct episodes, more like a baseline.
Kind of like a baseline of elevated mood and energy, yeah. Not necessarily episodic in the same way we think of distinct hypomanic periods.
Interesting. So more sustained, maybe less intense overall.
That's a reasonable way to think about it.
Mm-hmm.
Then there's cyclothymia.
Okay.
Our sources describe that as a condition with ongoing mood swings between hypomania-like symptoms and depressive symptoms.
Right.
The important thing here is that these ups and downs don't meet the full criteria for either a manic episode or a major depressive episode. They're sort of sub-threshold.
Okay.
And often, people with cyclothymia have periods of relatively normal mood in between these shifts.
So it's like a more moderate but kind of constant back and forth compared to bipolar disorder.
Exactly. A more persistent but less extreme pattern of mood swings.
Gotcha.
And when someone has experienced at least one episode of hypomania and at least one episode of major depression, both meeting the full criteria, that's when we talk about a diagnosis of bipolar II disorder.
Okay, so bipolar II is hypomania plus major depression.
Correct. And the sources even note these episodes can sometimes show seasonal patterns.
Really? Like how?
Well, maybe depressive episodes are more common in autumn or winter, and hypomanic episodes pop up more in spring or summer.
Wow, that's fascinating. Makes you wonder about sunlight, environmental triggers.
It does. Lots of research looks into that.
And it's also important to remember that potential for progression, isn't it?
Oh, absolutely.
The sources warn that if it goes untreated, especially in people who are predisposed, hypomania can actually escalate, transition into full-blown mania.
Yes. Which could include psychotic symptoms.
And that shift would then mean a diagnosis change to bipolar I disorder.
That's a really critical point, yes. What starts as hypomania without the severe impairment or psychosis can escalate.
Right.
And our sources also highlight that quite often, before the first really noticeable hypomanic episode, there might be a history of depression. Or maybe mixed mood states. This can start showing up in the mid to late teens, and sometimes, it gets mistaken for typical teenage angst or moodiness.
Which could delay getting help, I suppose?
It definitely could, delaying a proper diagnosis.
That makes a lot of sense.
Yeah.
Teenage years are turbulent anyway, easy to overlook the early signs.
Mm-hmm.
I also saw a mention of a connection to narcissistic personality disorder. How does that fit in?
Yeah, the sources do indicate there can be an association.
Okay.
This might be because some features can look similar on the surface, like that inflated self-esteem or grandiosity we mentioned.
Right.
But it's important to remember it's just an association. The underlying causes, the overall pattern of symptoms, they're different between hypermania and bipolar disorder and narcissistic personality disorder itself.
Okay, got it. So shifting gears a bit, let's talk about what might be causing hypomania. What do we know about the mechanisms behind it?
Well, as the sources explain, mania and hypermania are often studied together, right, in the context of bipolar disorders.
Makes sense.
And there's a general understanding they likely share similar biological pathways. One prominent theory mentioned is the monoamine hyperactivity theory.
Okay, what's that?
It's the idea that an overactivity of certain brain chemicals, neurotransmitters, specifically norepinephrine and dopamine, these are like messengers in the brain, could play a role, especially since some drugs that increase the activity of these chemicals can sometimes trigger hypomania.
So it's a bit like a chemical imbalance in the brain, to simplify it.
In a simplified way, yes, that's the concept. Another related theory suggests maybe a decrease in regulation by serotonin. Another key neurotransmitter over these other monoamines could tip the balance towards either depression or mania, depending on the specifics.
Complex interactions.
Very. Our sources also point out an interesting link. Sometimes lesions or damage on the right side of the brain, particularly the frontal and temporal lobes, have been associated with mania.
Ah, so a more physical structural link, potentially.
Exactly. It just underscores how complex mood regulation is. Multiple factors involved.
Definitely.
And finally, it's worth noting that hypomania can sometimes be brought on by medications themselves.
Oh, right. Like a side effect.
Yeah. And the sources indicate that in those cases, lowering the dose, stopping the medication, or maybe switching to a different one can often resolve the hypomania.
That's good to know.
Yeah.
Always important to consider medication effects when mood changes happen.
Absolutely.
Now, let's get a bit more specific about how hypomania is actually defined, like clinically.
Yeah.
Our sources mentioned the DSM-IVTR criteria. What are the key elements there?
Okay, so according to the DSM-IVTR, which was a standard before DSM-5, but the core ideas are similar. A hypomanic episode involves a distinct period, at least 4 consecutive days, where there's a noticeable and persistent mood change, either elevated, expansive, or irritable.
Right.
And during that time, you also need at least 3 additional symptoms if the mood is mainly elevated or expansive, or 4 additional symptoms if the mood is mainly irritable.
Okay, 3 or 4 depending on the main mood type.
Exactly. And crucially, these symptoms need to represent a clear change from the person's usual behavior and mood when they're not depressed.
Right, a definite shift from their baseline.
Precisely.
Okay, and what are some of those specific symptoms that are listed?
The DSM-IVTR lists several, things like pressured speech.
Talking really fast.
Yeah, talking more rapidly, feeling an urgency to speak. Also, inflated self-esteem or grandiosity. A decreased need for sleep, we mentioned that.
Right.
A flight of ideas, or the feeling that thoughts are racing, being easily distracted.
Okay.
An increase in goal-directed activity could be social, work-related, even hypersexuality, or just general psychomotor agitation, feeling restless. And finally, getting involved in pleasurable activities that have a high potential for negative consequences.
The risky behaviors again.
Exactly. Like impulsive sexual encounters, reckless driving, getting into arguments, maybe making foolish business decisions or spending sprees, inappropriate stuff.
That paints a pretty clear picture of the kind of changes that can happen. So what about treatment? If someone is experiencing hypomania, what are the typical approaches the sources discuss?
Well, the sources indicate that anti-manic medications are really the primary way to manage acute hypomanic episodes.
Okay.
And also to help prevent them from coming back. These are often used alongside different kinds of psychological therapy, like CBT or psychoeducation.
So meds and therapy together.
Often, yes. The recommended length of treatment can vary, maybe 2 to 5 years, sometimes longer, depending on the person.
Right.
Now, antidepressants. They might be needed if there's also significant depression, but they're used very cautiously.
Because they could trigger hypomania.
Exactly. There's that risk. Sertraline, for instance, is mentioned as one where there's been some debate about its potential to flip someone into hypomania.
So finding the right medication balance sounds like it can be quite delicate.
It can be, yes. It often requires careful monitoring and adjustment.
What are some of the specific medications mentioned in the sources?
They list several types. Antipsychotics are common, like holoperidol, olanzapine, paliperidone, ketapine, risperidone, ziprasidone. Then there are other anti-manic meds that aren't antipsychotics. Mood stabilizers, essentially. Things like carbamazepine, lithium, oxcarbazepine, valproate.
Lithium's a classic one, right?
It is, yeah. Still very effective for many people.
Okay.
In the short term, maybe for agitation or severe excitement, benzodiazepines like clonazepam or lorazepam might be used.
Just to calm things down quickly.
Right. And then there are some other medications mentioned like gabapentin, lamotrigine, levetiracetam, talpiramata, but these are generally seen as less effective specifically for hypomania itself, though they might help with other symptoms sometimes.
Okay, so quite a range of options, but it sounds like a careful, often combined approach is needed.
That's usually the case.
Finally, let's just touch on the historical side. Has hypomania always been recognized like this?
It's interesting, yeah. The sources mention that ancient Greek physicians like Hippocrates and Aretaeus described a manic personality type way back then.
Wow.
But in 19th century psychiatry, mania was a much broader term. It covered lots of things we'd now call different mental illnesses.
Ah, okay.
And the hypomania sometimes got lumped under concepts like partial insanity or monomania.
Right.
The real turning point mentioned is 1881. A German neuropsychiatrist, Emanuel Ernst Mendel.
Angle.
He specifically introduced the term hypomania, using hypo, meaning under in Greek, to describe a milder form of mania.
Ah, so he coined the term we use.
Essentially, yes. He defined it as like the typical picture of mania, but less severe, almost incomplete.
Okay.
And then more specific operational definitions, the kind we use for diagnosis, were developed later, mainly in the 1960s and 70s.
So it reflects our understanding getting more nuanced over time.
Exactly, a growing understanding of the different shades within mood disorders. It shows how our diagnostic categories and understanding of these complex states are always being refined.
Yeah, that makes sense. Well, this has been a really illuminating deep dive into hypomania.
Glad it was helpful.
Just to quickly summarize the key things, we're talking about an elevated mood state, increased energy, activity. But the crucial distinction is without the significant functional impairment or the psychosis you see in mania.
That's the core difference, yes.
It's closely linked to the bipolar spectrum disorders like bipolar 2 and cyclothymia. And being able to accurately differentiate it from mania and even from just, high energy or personality traits is really vital for getting the right diagnosis and treatment.
That's a concise and very accurate summary. Understanding those distinctions is absolutely essential.
So here's the final thought for you, our listener, to consider. Given those reported connections between hypomania and periods of maybe enhanced creativity or productivity, what might this tell us about the really intricate relationship between our mood states and how we express ourselves or get things done? Is there a point where that heightened edge, that energy, actually becomes a liability, where it starts to impact overall well-being and stability? Definitely something to think about. Thanks for joining us for this deep dive.